Welcome to Protocol Review. Today we're going over general patient assessment. We'll also talk about initial medical care. And throughout the presentation, I've also grouped in the initial trauma care protocol. And at the end of the day, the differences between the medical care and trauma care are really insignificant. So we're going to blend all of those together today. So looking overall at the protocol objective, you'll find initial medical care on pages 3 and 4, and then initial trauma care on pages 43 and 44 of your protocol book. The overall objective here is just simply to provide a guidance in the systematic approach to patient assessment and treatment of life-threatening injury or illness. And that systematic approach is really important. Many of us went through EMT program, and the first thing they taught us was how to conduct a basic patient assessment. And for a lot of the more experienced care providers in the room, you're thinking back, oh wow, that was 10 years ago, 15, 20, 25 years ago maybe. Really though, that is the most fundamental skill that any of us can perform. Quarterly we practice doing King Vision and everything else to show that we are proficient. At the end of the day, though, really a basic assessment is the most important thing that we can do. And if we can't do this well, if we can't do it proficiently, we're going to end up missing a lot of otherwise treatable issues with our patients. So in general, what constitutes an assessment? And this is a definition that I just kind of came up with, but I think it sums it all up. And it's any interaction with a patient where the care provider makes general observations regarding the patient's presentation, behavior, or verbal complaints. All too often we think that we have to actually touch our patients in order to assess them, and that's not the case at all. We can assess from a distance. We can simply look at somebody and perform an assessment. If somebody is pale and diaphoretic, we can see that from a distance. If somebody is tripoding and really working hard to breathe, we can see that from a distance. So even when we have one of those refusals at a 1050, oh no, I don't want vital signs, I don't want anything else, but yet we go ahead and we go through with the full refusal because we're concerned and we want to make sure that it's documented. We can still add an assessment into our report from that, just simply based on the patient's presentation, mental status, work of breathing, and everything else. We don't have to have a full set of vitals, and we don't have to actually palpate the abdomen or listen to lung sounds in order to completely assess our patient in those circumstances. So assessment and care at the point of contact. This is one of the things that the protocol really drives home. And I'm guilty of it myself, from time to time, especially you think about Walden Oaks and you're going there for a medical alarm. How often is it just a false alarm? Somebody or a kid accidentally pulls the string. Truth be told, though, the protocol is very explicit. Thou shalt take all of your equipment inside, and you will be prepared to treat the patient at the point of contact. Now, there are going to be some exceptions, right? If it's the scene itself is a hazard, maybe there's obviously your obvious hazards such as CO and everything else, but even sometimes animals could be an issue. If somebody has a bad allergy to cats and we go to the cat woman's house, hey, that's going to be a scene issue. If we cannot render care effectively due to a personal allergy or something like that, I think that that's a pretty good reason to move the patient out to the ambulance into our controlled environment. But generally speaking, the expectation is that we will render the initial set of care at the bedside or wherever it is that we actually locate the patient. So the scene size up is something that everybody performs, right? And there's always been discussion among the textbooks. Does the scene size up begin on arrival, or does the scene size up begin as soon as you're dispatched? And I would argue that it begins as soon as you're dispatched. Based on our CAD notes, based on any prior experience that we have with the address or the location, we're starting to kind of think through a lot of those things. So talking about scene size up, we have scene safety and BSI, which is going to be, those are things that have been driven into us since day one of first responder or EMT class. And consider how that's really evolved, especially BSI. The amount of PPE that we're wearing today in a COVID environment is incredible compared to what we've always worn in the past. N95s on every call, the use of gowns far more frequently. And really, when we talk about BSI, there's a lot more to it as well. So, looking first of all at scene safety, be observant of those obvious and hidden hazards. And I know it sounds kind of funny saying, hey, be observant of hidden hazards. What we have to do, though, is we have to have that 360-degree situational awareness. We have to have our head on a swivel, and we have to be able to anticipate hazards that may not be very obvious to us. And we've always thought about scene hazards being things like violent patients, hazardous materials, traffic, that type of stuff. But in truth, weather can be a scene safety issue. And even when we talk about hazardous materials, if you have ever seen that case study from Phoenix, where a fire department responded for a pregnant female at a McDonald's who fell, what ended up happening is the carbon dioxide, not monoxide, but carbon dioxide machine that they used in the carbonation of the drink station there had a leak in it. And so the carbon dioxide leak simply displaced oxygen in the environment and caused it to be toxic. And that's not necessarily a gas that we would consider to be toxic on a regular basis. Obviously we exhale carbon dioxide with every breath, but in this situation here, just because of the concentration, it became an issue. With BSI then, again, it's evolved significantly, but when we look at some of the more abstract ideas related to ways that we can isolate ourselves from body substances, it could be a matter of draping towels or blankets over somebody. If we have a patient that's spitting, putting an oxygen mask on them, utilizing bed chucks if a patient's incontinent. All of these things are all ways that we are trying to either contain or prevent any of these body fluids from getting on us or out into the environment. Mechanism of injury and nature of illness. So observe the scene for clues that may suggest potential injuries or causes for the illness. And I'll give you a brief example of a call that I was on one time. We responded for a full arrest, and it was a male subject that was found in the garage. And we got there and the garage door was open. We did our initial assessment and started working the arrest. Because the patient was in the garage, we literally threw him on the cot, put him in the back of the ambulance. It took us about 20 seconds to do it, and the entire arrest was worked in the back of the ambulance. And because everything happened so quickly there wasn't a lot of time to really look around and observe the scene. A few hours later, we were called back from the police. They asked us to check the, I'm sorry, no, it wasn't from the police. The hospital called, and they got the blood work back on that patient, and the carbon monoxide levels were off the charts. So we ended up getting called back. When we went back, we went there with the police, and we went inside to do some air monitoring, and we did in fact find some carbon monoxide levels. And what it was is the gentleman must have been working on a vehicle inside the car. When we really stood back and looked at it, some tools were out on the ground. The hood was up of one of the cars in the garage, and it looks like probably the car was running inside that closed garage, and that was the issue. Number of patients then. As soon as we can get on scene and identify the number of patients, the better. This is going to give us a lot of clues as to what types of additional resources we may need, how many ambulances, do we need extrication, those types of things. And from a command perspective, even if we can't necessarily give a full comprehensive triage report right away, if we can at least tell command, hey, we've got 3 patients or we've got 10 patients, they can get those resources mobilized, and then we can start to kind of narrow things down once we have a better understanding of the patient's condition. And then for additional resources, again, kind of an abstract idea. Additional resources, we typically think about calling an engine or a truck to the scene, or maybe asking for a helicopter if it's a level 1 trauma patient. But really, those additional resources, they could include language interpreters. It could be a health department thing. It could be senior services. It could be DCFS, law enforcement, public works if we need a salt truck, or if we need assistance with some type of technical rescue, such as a trench. Just a lot of different things. And we have to really kind of, again, consider all of the resources that are available to us. All too often we think of ourselves as the ones that have to solve every single problem. But in truth, we have specialists that are out there, and if we need their help, all we have to do is call and ask. All right, so let's talk a little bit here about primary assessment, and this is where we really start to get into the meat and potatoes of assessing our patient. And the primary assessment is comprised of several general categories, including the general impression, level of consciousness and AVPU, airway, breathing, and circulation. Now, when we incorporate trauma into this, we also have to consider C-spine control, and we also consider the fact that we're going to address life-threatening hemorrhage immediately, even before airway. So we're used to the ABC order of assessment and treatment. However, in the event that our patient is unconscious or unresponsive in any way, we actually flip that around, right? We do a CAB assessment. And if you think about the reasoning for it, it makes perfect sense. If we walk up to a patient that's unconscious, the first thing we're going to do is check their pulse to make sure that they have one. If they don't, we start CPR. So that CAB assessment is kind of a natural progression anytime we have an unconscious patient. So looking at general impression itself, whenever I talk to my students, I always teach it as kind of gut instinct. As you walk up and you see a patient, what is that gut feeling that you have? And if it's really bad, if it's kind of that oh crap factor, that's part of your general impression. And sometimes we even let little comments like that slip over the radio as we're pulling up and we're sizing up the scene. You hear the driver, the back step say something because it really kind of indicates just how bad the situation may be. And that general impression, it could be derived from what we see, from what we hear, smell, or even what we feel if we go up and we can start touching our patient. So now looking at level of consciousness and AVPU. All too often people seem to separate those and think that it's two separate things, but in fact they're the exact same. They work in tandem with each other. Looking at level of consciousness, if my patient is conscious, then that means that they are going to be alert, period. If they are unconscious, then we have to assess whether or not they are responsive to verbal, painful stimuli, or if they're just simply unresponsive altogether. So again, level of consciousness ties into AVPU. If they are conscious, then they are going to be alert. If they are unconscious, then we have to determine whether or not they are responsive to verbal, painful, or unresponsive altogether. So when we look at the relationships there, again, for a conscious patient, we're going to determine are they conscious and are they alert to person, place, time, and events, ANO times 4. If they're unconscious, then we go to that verbal, painful, or unresponsive scale. Looking next at airway then, airway can be assessed even again from a distance, and that can be assessed passively. If a patient is able to speak with us, no problem, engage in conversation, they're not speaking in 2 to 3 word sentences, they're not gasping, and there's no obvious labored work of breathing, we can assume that their airway is probably open and patent. If we need to, we may need to get up a little bit closer to our patient, especially for those unconscious patients, and assess a little bit more. Listen directly for specific airway sounds or look for any types of obstructions that may be present. Breathing then. Evaluation of a patient's breathing. We need to include effort, rate, and depth as we do that, and in some situations, lung sounds. If we are truly doing a primary assessment, and we need to transition from there into a rapid head-to-toe, lung sounds are going to come later on in the matrix. But if we have a conscious patient that's complaining specifically of difficulty breathing, this may be an opportunity for us to go ahead and listen to lung sounds. And that would actually fall into be part of the focused assessment more so than the primary. Circulation then. Circulatory assessment, we're looking at skin parameters, central and distal pulses, and when we are checking pulses, we should also include rate, strength, and regularity. So calculating a glass Calcoma score, probably a weak point for a lot of us. We don't do it all that often, but we should be able to do this on the fly, and we should be able to do it with accuracy. This is really the most objective way that we can identify the patient's overall mental status, and more importantly, any changes in their mental status. So looking at the chart here, eyes have a total of 4 points available, verbal 5, and motor response 6. And the way I remember it is I just recite in my head EVM 456, EVM 456. And really when you look at it, even dead people get 3 points, right? So everybody by default is going to get 3 points. A perfect patient with no mental status issues whatsoever is going to get all 15. And then we can assign, based on the patient presentation, any other points for your respective categories. Looking then at motor response, right? We have abnormal flexion or decorticate posture, or extension or decerebrate posture, right? For 3 points and 2 points respectively. In those situations, I always have people say, well, what happens if they're posturing and they're decorticate on one side and decerebrate on the other? And that actually is possible. That will happen. And whenever we have something that we're just not sure about which category or how many points to assign, we're always going to give the patient the benefit of the doubt. We're going to give them the higher point value if we're kind of torn between them. We're not going to give a half point or any other type of fraction of a point. And in doing so, it's more important to be able to document that a patient's condition is getting worse than it is to be able to document that it's getting better. So if we always give them the benefit of the doubt, if we go to reassess 3 or 4 minutes later, and now it's obvious that they should have received 1 point less, we can definitively say, hey, we've had a drop in the overall glass Calcoma score. So let's practice really quick and just do 2 quick patients and see if everybody remembers or can do this without looking directly at the chart. So patient 1. A postictal patient's eyes are open, but their pupils are sluggish to respond. The patient is unable to speak or generate any sound. An application of pressure to the patient's cuticle causes them to withdraw their hand. So what do you guys think? I'll give you a couple seconds to look that over and calculate it. All right, if you guessed 10, you would be correct. 4 points for the eyes. Even though they're sluggish to respond, that's not part of the GCS assessment, right? If their eyes are open spontaneously, they're going to get all 4 points. Looking down then at verbal, so unable to speak, generate any sound, anything at all, it's 1 point is all. And then for the motor function, because the patient is actually able to localize pain, right, that withdrawal and localization of the pain tells us that they should be deserving of the 5 points. If we were to apply pain to that hand, to that cuticle, and there was just a general shrug or a moan in response or something like that, but they weren't able to specifically withdraw the hand that we were applying pain to, then that would have probably dropped them down to 4 points. But in this situation, they were able to withdraw the specific hand, so it worked out just fine. Patient number 2, you're requested for an evaluation. The patient only mumbles in response to your questioning, follows you around the room with her eyes, and appears very weak when standing. I'll give you guys a few seconds. What do you think? If you guessed 12, you're correct. Again, her eyes are open. She's following you around the room, so that's a solid 4 points. With verbal, she's only mumbling, so those would be considered incomprehensible sounds, giving her 2 points. And then she is weak when standing, but the fact that she can stand tells you that she has full motor function. She would get all 6 points in this situation. Moving on to transport priority then. Stay and play, load and go. What hospital are we going to? Really consider why we stop to do a lot of the interventions that we do. All too often we'll stay on scene too long because we feel that, oh, well, if we don't have an IV before we get to the hospital, the nurse is going to say something to us. Our one and only priority is to provide effective patient care based on the patient's presentation. And if a nurse is upset because you didn't have an IV established when you got to the hospital, too bad. That's not our concern whatsoever. Now, if you should have had an IV established because that patient needed medication, fluid boluses, or something like that, that's a different story. We need to really manage our scene time. We need to think about what we're doing and why we're doing it. And at the end of the day, we need to stop wasting time on interventions that we do just because. And we have to be able to clearly articulate what we did and why we did it. And we have to be able to defend ourselves when we are questioned about it. And it's okay to be questioned about a decision that was made, about an intervention that was done. And at the end of the day, a decision that's made in the field may not always be agreed upon by the nursing staff or the physicians in the ED. But that doesn't matter. As long as you're confident in what you did and why you did it, and you can clearly articulate it, in most cases you should be covered. Moving into secondary assessment then, this is probably some of the more in-depth stuff. Where do we begin is always the first question. And with secondary assessment, our goal here is really to begin diving in deep. So primary assessment, if you think about it, is just quickly to identify any glaring life threats related to airway breathing or circulation. But now that we move into secondary assessment, we're going to dive a little bit deeper here. We're going to start looking more in depth as to what could be contributing to the causes of the patient's condition and what it is that we need to do to actually fix it. So our goal here with the secondary assessment is actually to identify additional life threats, but also to develop a differential diagnosis and a comprehensive treatment plan. With the secondary assessment, there are three primary components: a rapid physical exam, a focused exam, or vital signs with a sample history. We'll talk about those. So we do have the autonomy. What direction do we go? What do we want to do first? Do we want to try to get our history? Do we want to go with a rapid physical exam? Or is it appropriate to do just a focused exam? And that really depends on our patient's presentation, what they can tell us, whether or not we have to figure this out for ourselves. So in ideal circumstances, we have multiple providers performing multiple tasks simultaneously. If there's a group of 4 or 5 of us on scene, we can do all of these things simultaneously. But in reality, if there's 2 of us, one of us is talking to family or bystanders trying to get information, and the other person is tasked with assessing the patient to determine what's wrong, we do have to make these decisions. And my recommendation is that in most cases, if we have an unconscious patient or even just a semi-conscious or altered patient that can't definitively tell us what's wrong, we should be doing that rapid physical exam. We jump into vitals all too often, and vitals don't tell us anything about what's wrong with our patient. Vitals will tell us how wrong it is, right? How bad our patient's condition is. We can look at vital signs, we can look at blood pressure and pulse, and they've got a pressure of 86/50 and a pulse of 132, and it's pretty easy to say, hey, they're probably in shock, and in decompensated shock, of all things. But it still doesn't tell us what's causing the shock, and that needs to be our focus. We have to identify the underlying causes, and we need to develop those treatment plans so that we can begin to fix it. So vital signs themselves, again, I just said this, right? They're not enough to really tell us what's wrong with the patient, what's causing the issues. But we can certainly use them to assess the overall severity. Sample and OPQRST, getting a good quality history, this tells us a lot. We can start to paste together a lot of the clues that we have from asking good sample and OPQRST questions and go from there. And more often than not, a good sample history is going to lead us to the diagnosis for any patient who is conscious and alert. A rapid physical exam will lead us to the diagnosis if a patient is unconscious. When we do that rapid physical exam, we're talking 60 seconds plus or minus, right? A quick head to toe. Again, our objective here is simply to identify life threats that can be immediately corrected. And that's the only time that we should stop. If we do come across a life threat and we can do something to mitigate it, then we stop and do so. But if I'm doing a rapid head to toe and I come across a distended abdomen that is rigid, okay, that's probably a life threat. There's an internal bleed there, no doubt about it. But there's nothing I can do to specifically treat that bleed. So I'm going to continue going. I'm going to finish up my assessment. And we want to be sure that if we do have some grotesque type of injury or some type of obvious glaring issue with our patient, that we don't allow that to distract us from truly what's going on. And I always use the example of a scalp wound. If somebody has a laceration to the scalp, That thing bleeds and bleeds and bleeds. But rarely is anybody going to ever die from a scalp wound. Yes, they bleed a lot, they're very vascular, but typically those vessels are going to clot off relatively quickly, long before any type of hypovolemic shock would set into play. However, that amount of blood on the ground and around the head, being such a sensitive part of the body, can easily distract a care provider from continuing to work down the body and actually identifying something like a flail segment or a sucking chest wound, something that we could fix and identify a lot quicker. When we do a physical exam, right, and we look at all parts of the body compared to specific parts of the body, in all cases, we're looking for general soft tissue wounds, musculoskeletal injuries, tenderness, deformities, all those types of things. But then we can also get a little bit more specific. And in the head, right, we see crepitation, but look even beyond that. We're looking also for signs of CSF in trauma patients. Identifying or looking at the pupils will tell us a lot about neurologic function, and that's for both medical and trauma patients. When we get down to the neck, looking for that JVD, jugular vein distension applies to, again, both medical and trauma patients, right? A pericardial tamponade or tension pneumothorax could cause JVD, but also any type of cardiac arrhythmia where we're reducing preload to the heart, that alone could cause JVD as well. So again, both medical and trauma patients are going to have that. And you can see as we go down the list that every part of the body has something specific that we should be looking for. And especially if we're documenting in our report, these are the types of things that if we suspect chest trauma, we shouldn't just simply say, okay, we found bruising from the steering wheel. We should put in there, okay, we identified and we assessed for, we did not find paradoxical motion, no crepitation upon palpation. Heart tones seem to be okay, and I know heart tones aren't something that most of us assess for, but we need to be able to document those pertinent negatives just as much as the pertinent positives. Now, in a perfect world, when a patient is awake, they're conscious, they're able to talk to us, and they seem to be a relatively good historian, then we can actually perform a focused exam. They tell us exactly what's wrong, where it hurts, how it hurts, and they can describe all of those things. They can answer all of our sample and OPQRST questions. Then we need to actually go ahead and focus on that. And it makes perfect sense. If we arrive to a patient and the patient says, I have a headache, and you start palpating the abdomen, they're going to think to themselves, what's going on with this person? We need to focus directly in on their area of chief complaint. So looking at the head itself, and we talked a lot about differences between medical and trauma, and again with the head, it's going to be very similar. In a medical patient, we may not be looking for any type of crepitation. We're not looking for a deformity to the skull or contusions or anything, but we should be again identifying the airway. We're going to look at pupils, and there from time to time could still be discoloration issues that are secondary to a medical condition. Outward physical signs may suggest internal injury. So looking at this here, battle sign, right, that is going to be the bruising behind the ear, and that would more than likely be indicative of some type of trauma with internal bleeding. Now, I will tell you that it takes a long time for battle sign to set in. So if you are seeing this, the head injury, the bleed is probably pretty well progressed by this point in time. And I wouldn't be surprised if the patient was already deceased or circling the drain by the time we would actually start to see these types of physical presentations. Assessment of the chest, same thing. Looking for very specifics, right? That paradoxical motion gives us a good indication that there could be a flail segment. Unilateral chest rise or uneven chest rise in general could be a big thing. Also looking at that overall work of breathing. And remember that lung sounds are going to be reserved really more for our detailed assessment or in some cases a focused assessment. But if we're doing a rapid trauma head to toe, lung sounds should not be included in that initial head to toe assessment. Assessment of the abdomen then, looking for basic soft tissue injuries and that distension. Remember that rigidity, right? If you press down and it feels like there's a rock underneath somebody's stomach, and I'm not talking about defined abs or muscles. I'm talking it truly feels like there is a rock sitting underneath their skin. That's typically indicative that something came in contact with the perineum there. And it could be blood, it could be bowel content, it could be bile, but some type of liquid, some content got out of where it belongs and came in contact with the lining of the stomach. And when that happens, that rigidity sets in almost instantly. So you may not be identifying the specific location of a bleed per se, uh, but it is going to tell you that there could be something significantly wrong. And even in the absence of a bleed, if it's a perforated bowel, if you think about the infection that's going to set in from that occurring, this is still going to be a time-sensitive patient no matter what. Moving down to the pelvis, uh, probably instability or crepitus is going to be the thing that we're looking for the most. Maybe one of the more easier signs to identify, but don't forget to look for those shortened and rotated extremities as well. And those are going to be a good indication that there could be a dislocation more so than anything else. Remember too that the pelvis, especially with males, is almost like a hollow bowl, and we can lose liters of blood into the pelvis without any obvious outward signs. So when we are dealing with potential pelvic injuries, even if we don't identify any instability, even if we don't identify that crepitus, just simply having a complaint of pain or anything like that in that region could be enough that it transferred energy into the pelvis there, that we do have some type of bleed, and it could be a while before the patient starts to present with any outward signs. Looking then at extremities, pulse motor sensory is probably the most important thing. We want to identify if they have good distal circulation beyond the point of any types of injuries. We're also identifying for potential signs of compartment syndrome or anything else, but more often than not, it's going to be simple soft tissue or musculoskeletal injuries. And again, we just want to identify that they have that good circulation beyond the point. Once we've completed our head to toe assessment, then at this point we can go ahead and start providing that ancillary care, or comfort care. And simple things like managing their pain, treating for nausea and vomiting, I think are obvious, but also positioning and comfort plays into that as well. If the patient's conscious and they can self-position themselves, let them. And if they're in pain and they want to curl up in the fetal position, that's fine. Restrain them, properly on the cot with in that position, and it's not a big deal. Obviously, in most cases, a conscious patient is going to be in the semi-Fowler's position. It's going to be most comfortable for them. And an unconscious patient, more often than not, will be in the supine position. Reassessment is done on a regular basis and is really reflective of the severity of the patient. If the patient is critical, we're reassessing constantly, right? I mean, it's a constant scan head to toe. We're constantly reassessing our interventions. We're looking at medications. We are looking for changes in, discoloration or anything else. It's just a routine 24/7 type thing until we transfer care. For patients that are more stable, some of our patients that honestly didn't even need to be transported in the first place, our reassessment's probably going to be a little bit more relaxed. But don't become complacent, right? Even a patient who appears to be stable, 1 minute can turn around very quickly another. So have your head on a swivel. And that's it. This was a pretty basic presentation. It's really a basic review. I do encourage you to actually go through and look at the protocol book. There's a couple other basic things in there that you should keep in mind and consider, but I didn't feel it was appropriate to actually go through line by line, right? Everybody's able to go through and read that for themselves. So I hope you enjoyed it, and we'll see you soon.